this brings us to the last session of this symposium, and that is a very special one about VT ablation in specific situations. And it's my pleasure to invite the first speaker, Katja Zeppenfeld, and she will talk about ablation in previously corrected congenital heart disease. As you know, Katja published a very important paper on tetralogy of Fallot, and she's really expert in the field. So we are happy to hear the presentation.
Thank you very much, and thank you for staying. So as you obviously know, congenital heart disease is not one disease. There are several different malformations, but not all are comparable related to VT. And this is actually from just an ICD, meta-analysis of ICD studies showing the distribution of congenital heart disease across these studies. And the vast majority of patients implanted for ICDs are patients with tetralogy, followed by the TGA group. And also from these studies, we do know some details of the VT, and the majority of the Fallot population do have monomorphic VTs, more than 80%. In the other malformations, in particular the transposition patients, they very often have polymorphic VT. We have much more heart failure-related VTs. And this is also reflected, and please don't read this data, I just wanted to summarize all data that are available over the last 25 years in patients with congenital heart disease. And you can see that most reports are indeed tetralogy patient, and then VSD patient or complex DGAs, and then there's one series on Epstein patients. They also looked at the mechanism. The vast majority have macroentry as an underlying VT mechanism if they have looked at it in the studies. And accordingly, the endpoints of ablation have evolved over time, non-inducibility in the early studies, but more and more because it's macroentry using certain areas. A conduction block across linear lesions is also much more implemented in the congenital group. And it all starts actually with this very nice paper. It's a surgical study of epicardial mapping during ongoing VT in a Fallot patients. And you can really see that this VT is rotating around the RV incision, and you can see some conduction delay between electrodes E and F. But you can also look differently, and you can just say this VT is using two anatomically determined isthmuses, namely between the incision here and the tricuspid annulus and the incision and the pulmonary annulus. This is the first description of anatomical isthmus 1 and 2, which we have completed in 2007 by endocardial mapping, because the other most important isthmus, in particular this anatomical isthmus 3 here between the VSD patch and the pulmonary annulus, is only mappable from the endocardium. Therefore, the surgical studies have missed this. And then very rare that is anatomical isthmus 4, which is down here between the VSD patch and the tricuspid annulus. The majority of Fallot patients have a membranous VSD, meaning that this is a continuity between VSD patch and fibrous tissue. So the most important substrate is anatomical isthmus 3. And if you look at the change in the surgical approach in Fallot patients, in the old days there were these huge RV incisions, and there are abandoned, and nowadays we have a transatrial transpulmonary approach with a small transannular patch in the majority. So this abolished actually anatomical isthmus 2, and this anatomical isthmus 1 is broad and can probably not even considered isthmus anymore. And we can reconstruct this kind of anatomical images in our EP lab, and this is a bipolar voltage map of a very young Fallot patient. And typical for these patients are these very fast VTs, 260 beats per minute. And this is his voltage map. It's just color coded with 1.5 millivolt as an upper threshold. And we don't really use this voltage mapping, but we look in particular in these areas where we expect the anatomical isthmus. We look for non-capture. These are the gray checks. And you can see this is a transannular patch location. This is a tricuspid annulus, and this is anatomical isthmus 1, which is indeed very broad and normal. In contrast, this is anatomical isthmus 3 between the VSD patch and the pulmonary valve. You see some low voltage electrograms. These are again the non-captured points here. And this is quite narrow with a width here of 16.7 millimeter between the anatomical boundaries. if you have such a patient, and I just would like to emphasize this, even if you know that the substrate is very often located in the RVOT, map the entire right ventricle, because in fallow patient you can have surprises, generally in all congenital heart disease patients, because sometimes they have scarce and unexpected areas. This is a down patient, a tetralogy of Fallot, and he had large free wall scar with electrograms which resemble post-infarct electrograms with low conduction, and all his VTs were related to these areas, and we had good pace maps of the 3 induced VTs, and we just target the abnormal electrograms like we do in other substrate modification, and render him unusable with that. And by the way, the anatomical isthmus 3 was already blocked, and I come back to that in a second. So once we have these anatomical isthmuses, and I always make the point, all fallow patients have anatomical isthmuses. So this is not interesting to know. Interesting to know is if they are arrhythmogenic or potentially arrhythmogenic and relate to VT. And we all know one important player is conduction slowing. So we have started years ago to look at the conduction properties of these anatomical isthmuses, and up here this is the voltage map of our young patient, and here is the same map just displayed as an isochronal map or activation map during sinus rhythm. And to estimate the conduction velocity, we don't take this abnormal electrograms. It's also very important to know around the pulmonary annulus, very often you see fragmented electrograms. It does not necessarily mean that they are arrhythmogenic. This is just the border zone to fibrotic tissue in this area. But it's important to, if you would like to calculate the conduction velocity, it's important to look at the normal voltage electrograms at the entrance and the exit, because here you can take the downstroke of the unipolar signal to annotate your local activation time. And then you look do you measure at the entrance and the exit, and then you can calculate the time, you can measure the distance, and we have here a conduction velocity of 0.43 meter per second, which we consider abnormal. But if you only display your map, and I show it on the right, as a propagation map here, during sinus rhythm, you see already on eyeballing the conduction slowing in this area. And this was indeed the area which was related to the fast VT in this patient with a typical exit site high at the infundibulum septum. So we have done this in a quite large series of fallow patients, and just to see, can we identify arrhythmogenic isthmuses without even inducing VT? And this was the results of the first group. So 28 patients were inducible for 41 VTs, and in 37 we could relate the anatomical isthmus to a VT based on classical VT, which is entrainment or termination of VT during RF application. And you can see the characteristics of anatomical isthmus here, 1, 2, 3, and 4. Proven related to VT, this is a plus, and the other anatomical isthmus came from patients that were non-inducible for VT, which are mainly mapped in our lab before revalving also. And what you see is that all VT-related isthmuses were in particular narrow, but there's a huge overlap. But a good discriminator is indeed conduction velocity. So all VT-related anatomical isthmus had a conduction velocity of less than 0.5 meter per second, and we are using this now as a cutoff also for preventive treatment in patients that undergo resurgery. There are pitfalls of these measurements, and this is important to realize, because nowadays we have more and more fallow patients with this narrow crest complex. And it's important to picture the activation of the right ventricle in a patient with narrow and a broad crest complex or proximal right bundle branch block or right bundle branch block due to the incision. Because in this patient we had only a very small low voltage area, and this is the activation map here with an entrance and exit electrogram here at these 2 points. So this would be 0.81 meter per second, which is normal. But if you look carefully and if you remember how the normal RV is activated. It's activated, the earliest activation, this is from old Dura paper, is the anterior papillary muscle, and then activation spreads towards the anterior septum and towards the air-free wall, and then it propagates back to the infundibulum septum. So you get collision or wavefronts exactly in this area, and then the latest activated area is the basal peritricuspid region. So if you now start to to bring the second catheter up and pace here, then all of a sudden you can unmask your conduction delay. And this was actually also slow conducting anatomical isthmus, which was hidden by this collision of wavefronts at this particular area. So important for narrow crest complex, if you map this area, you have to bring up a second catheter to really prove that this is normal or fast conduction in this area. So once you have identified, and this is again a patient with a right bundle bench block, in this patient there is a broad septal activation from the left. This is different. Here you can really determine your conduction slowing during sinus rhythm without additional pacing maneuver. And once you have identified such a slow conducting anatomic isthmus, you do your ablation, which is a linear lesion transecting this area, connecting the unexcitable sites, which I have shown earlier. This is a VSD patch to the pulmonary annulus. And then you can remap, and this is shown on the right side, where you see all of a sudden a change in activation sequence, and now the latest activation is not the periotricuspid region, but the other side of your ablation line. So this is now a shift towards the RVOT as latest activated areas. Important, I mentioned in patients with narrow crest complex in particular, it's not enough to perform remapping during sinus rhythm, and this is what we do right now routinely in all patients. We do differential pacing like you all do with CTI dependent flutter. So you record and pace then close to the line and remote from the line, and then you measure your stimulus to local electrogram, which should be shorter if you move away from the line, and you can do the same thing the other way around to at least get some arguments for bidirectional conduction block. There's also one important limitation, in particular by young patients, because conduction around the RVOT can be very, very fast. And even if you get a positive result here, it can be still slow conduction. So we use additional arguments like non-pacing along the line with high output pacing. Once we have introduced this, and this is years ago actually when I was in Boston, we have defined procedural success as non-inducibility of NEVT and transection of the anatomical isthmus. This was the first cohort of mixed cohorts. The majority were follow patients, and as you can see, the cycle length was quite short. So these are fast VTs in the majority of patients. And if you achieve conduction block and non-inducibility, this is a complete success group, then the outcome in terms of monomorph VT is very, very good, and we still follow the patient. And we have, in this patient population, I show you the long-time results in a second, no recurrence of a monomorphic VT. There is one patient who had an episode of VF on the ICD, but this patient had already a CRTD device at the time of ablation and biventricular heart failure. So there is certainly a competing risk if patients have advanced dysfunction, in particular of the LV. The same results were published by another group, similar. It's a small series, but still quite convincing. Again, a mixed cohort of patients where they also have defined procedural success in non-inducibility and conduction block across the isthmus. So no patient with confirmed isthmus block had VT recurrence in this series, but the two whom they could not confirm isthmus block, these two patients had recurrence of a sustained VT. So I think this further supports the importance of conduction block as an endpoint of ablation. These are more recent data, not published yet, from our series, 125 patients that have been mapped actually for several reasons. Could be VT, could also be risk stratification or prior to revalving, which is again routine in our lab now. And I just would like to show you that those patients in whom no slow conducting anatomical isthmus was identified, and they had no other electroanatomical substrates, so no other abnormal regions in the RV. There was no event during long-term follow-up. In those that we did ablation, you see one patient here had a VT recurrence, is a patient with heart failure. The other patients, if you look at those with a preserved biventricular function, there was also no recurrence. But in patients where you fail or you don't do anything, occurrence or recurrence is quite high. So this supports, again, the link between this substrate and VTs, but also that it's probably important to treat these patients. And we do this preventively. We have a slow conducting anatomical isthmus in patients that undergo revalving. And nowadays, there is a shift from this surgical revalving. This is a patient, you see this huge pulmonary coronary valve regurgitation, so it's a dilated RVOT, so these patients still need surgical revalving. And in our lab, we use these homografts here, and I help you through this image to see how this is sutured, because this is upside down of this image. So this is would be the tricuspid annulus here. This is a VSD patch, and this is the suture line here of the homograft. So it's covering the entire infundibulum septum, so this area. It makes it inaccessible for ablation later on. And nowadays there are more and more catheter valves placed, and if you look at these valves, they also cover the majority of the RVOT. So this is also something which makes it very difficult to assess later by ablation. And it's very easy for the surgeon, and we do this at the beating heart, and there's a cryoprobe here, to just transect this area. Usually it's 2 or 3 applications maximum, and we measure, and these are temporary wires, conduction block in the operation room in 2 directions to make sure that this is also an achieved endpoint, and not only doing it empirically without having this endpoint. How important this is that two nice cases to illustrate. This is a patient who first underwent surgical ablation, and then there's a melody valve, a second percutaneous procedure for regurgitation. And we were unable to ablate this anatomical isthmus 3, which was responsible for VTs from the right side. But this is just the projection of the aorta, so we were able to, just at the opposite side, and this is actually the side on the RV where we are just ending in the struts here of the melody valve, but the homograft is going more down here. And this was just the opposite side where we could terminate VT from the aortic root. And this was a successful site, but very often we are not successful. And there's another patient, a very young man with fast VTs from the anatomical isthmus 3, with here clockwise activation. So the clockwise activation depends how you look at it, if you're from the anatomical map or from this image. But it's just rotating in one or the other direction with different exit sites. So this is an RS here, the typical LV septal exit site, and this is a left bundle bench block like with a late transition. So this is the exit site across towards the free wall, and we were not able to ablate this patient because, and you can see here the situation. This is the homograft. This is the distance between the aortic root and this posterior RVOT, and on the right side you see the activation map during sinus rhythm. And this is the signal here which we could record from the aortic root. This is just bridging the area here with slow conduction, and we did try from both sides, but we could not could not abolish this signal, and unfortunately this patient had received an ICD. Otherwise we would probably have avoided it. So in conclusion, the type of the congenital heart disease and the surgical repair determines the substrate for VT. In particular, the modern fallow population has in particular one substrate, and this is this anatomical isthmus 3 between the VSD patch and the pulmonary annulus. The same substrate can occur in patients with complex TGA, because these patients also have a VSD in a similar location or after VSD closure. And fortunately, we can identify this kind of substrate by electroanatomical mapping, and we can ablate this during sinus rhythm with relatively high procedural success rate. I hope that I could show you that it's important to map the entire RV, not only restricted to the RVOT in the fallow population. Substrate mapping for narrow QRS complex requires pacing close to the anatomical isthmus, in particular for the endpoint of ablation. To confirm a conduction block across the line, you also need the second catheter bringing up to the RVOT to confirm that you have conduction block. And because of the potential inaccessibility after surgical, and I think also after transcatheter revalving, I think this mapping and eventually preventive ablation should be done in all patients with a slow conducting area already, to prevent this frustration in the future that we cannot assess a substrate by ablation. So thank you very much for your attention.
Katja, since you are leaving, maybe we can ask for questions. Anybody wants to ask any question to Katja or any comment? It was so impressive. Thank you very much. And Next talk is by Pierre on Brugada syndrome.
Thank you, Joseph. Good afternoon, everyone, and thank you for staying. Thank you. I want to acknowledge the help of my colleague and friend, Frédéric Sacher, who has more expertise than I do in the ablation of ventricular fibrillation in the context of Brugada syndrome. Some disclosures. If we look at the literature, I think the first paper to describe how ventricular fibrillation was initiated in this condition was by this Japanese group. So they described these VPBs that consistently were preceding and inducing, in fact, the ventricular fibrillation. And that's also something we noticed in Bordeaux, and Michele Isaguer and Mille Zossini and Fred Sacher, they've been working a lot on this condition and other conditions for ventricular fibrillation, as you may know. And they have described the ablation targeting the trigger for these ventricular fibrillation events. It's not something easy, of course. You have to choose the right moment, and the best moment for that is right after a ventricular fibrillation episode. They typically would come with in the form of storms with several VF episodes, and right after that, when it starts to slow down, you have a good window where you still have frequent VPBs, so that you can use that to guide your ablation. There are limitations, mostly that, sometimes it's just too much arrhythmia, and it's a pretty frightening moment to get started in, you don't have that many isolated VPBs. Each VPB starts a ventricular fibrillation event, so not very comfortable ablation, and you may also have too few ectopics to guide your ablation. So it's this strategy that is aiming to target the trigger that initiate ventricular fibrillation in these patients may work, but it's not always easy. And we are frequently lacking the 12-lead ECG because this is an alternative. You could, use a 12-lead ECG with some ectopics and then do some pace mapping during your ablation procedure to get closer to the site where it may come from. And particularly when it's originating from the right Purkinje network, that might be a good help. But the trigger may also come from the RV myocardium. This is not rare. So some substrate ablation has been proposed, and probably the first one to propose this approach was Weena Demani. So this is from his original publication in Circulation, where he described, was no surprise, that substrate was pretty much epicardial and on the RV outflow tract, with some abnormal potentials, which are in fact interesting in the debate whether this condition is a depolarization or a repolarization abnormality. Anyway, you could describe the ablation of these abnormal potentials that I may call lava, because not all of them are late, but they are definitely coupled with the rest of the myocardium. And then we also used this approach and described that it was interesting to observe the reduction of the ECG pattern for the Brugada syndrome, and the spike aspect was going down, but it's not necessarily something you would see during the ablation, which means that you can't use that as a endpoint for your ablation. Reason probably being that the ablation itself would create quite some inflammation, and you may have persisting ST elevation, probably due to that, and then it flattens out. And Brugada and Paponi also described this phenomenon, which is really interesting. Now, high-density mapping catheters are particularly suited for that. This is you don't see it very well, but this is a pathway catheter. Not the best catheter to map endocardially, because the loose end electrodes may produce quite some mechanical ectopics, but epicardially it's really good. It's much easier, whatever catheter you use, but particularly this one. And you may record these, well, in our experience, these potentials are pretty sharp, high frequency, again, poorly coupled, near field type of potentials. It might be very different from other publications where the potentials appear more low frequency. Not sure why, probably some filtering issues. If the substrate is not very clear to you, you may use Ajmelin. And clearly it will aggravate the poorly coupled nature of those potentials, which are your target for that substrate-based approach. It's something to be used with caution. I mean, patients with severe Brugada syndrome may react poorly to Ajmelin, and you may end up with a difficult situation with a lot of ventricular fibrillations to deal with. Again, in some other reports, the potentials were not high frequency, even though they were poorly coupled. Not sure exactly why. But the impact on the substrate you identify may be very significant. And in this case, the substrate increased from 12 to 18 centimeters square, which is 50% more. So it's really unmasking probably some more areas. Now, it's not always limited to the RVOT, and in fact, the RV free wall, typically basal, is not rare. And you may even have extensions to the inferior wall of the right ventricle. Pretty much, in fact, the spots that you may see as well with some RVRC patients. Again, these potentials are poorly coupled, and if you use program stimulation, you will definitely demonstrate that, which in my opinion favors the hypothesis that this is a depolarization rather than a repolarization issue. But there are it's probably a heterogeneous condition with some patients having one or the other or both possibly. Anyway, you can demonstrate some changes in the activation of those polycoupled potentials by pacing S1, S2, as shown in this example. And here, you're losing part of the near field high frequency abnormal potential, as shown here, and it translates into a complete change in the activation sequence. You nicely distinguish the far field from the near field component by doing so. So it's quite likely that there are some significant condition disturbances in this condition that are mostly localized epicardially. I know that we at Imani had a chance to take some biopsy samples during surgery for some of those patients and demonstrated some fibrosis in there. It's not something we've seen. We've been looking hard with my friend Hubert Cochet to identify this with MRI, and it's probably below the resolution of the MRI. And we know all the limitations that come with fibrosis detection with MRI. And so I still think that this exists and is just below the resolution of MRI. Maybe the photon counting CT scanner will help us identifying this kind of substrate, which would be highly interesting, of course. Epicardial ablation is where we start because this is where the substrate is. And sometimes you have a coronary artery from the right coronary artery that is in the way. And we talk about the, I'd say the unexpected impact of pulse field ablation, at least with some of the recipes we are using at present time, because they were not completely safe versus the coronary arteries. And Elad reported this neointimal hyperplasia, which resulted in some degree of stenosis. But if you use RF on top of a coronary artery, it's not going to be something limited. It's going to be a coronary occlusion most often. So anyway, I have no experience of using pulse field because of a coronary artery being in the way between my ablation catheter and the target. But this happens with this condition, and it happens with IRVC as well. And so in this case, what we like doing is to get endocardially facing the area we want to ablate. And even if you don't see a substrate from the endocardium, you still can deliver. The RV wall thickness is typically less than 4 millimeters. This is something you can get with RF, and it may help and be safer than killing the coronary artery. So this is the target that we're recording epicardially during ablation from the endocardium, and you see that it did work. The risk for reconnection is higher as compared to direct ablation, but you have to compromise. So ablation targets high-frequency signal that are polycoupled. You may want to call them lava or not. Not a big deal. Better identified with high-density mapping catheters. I think these catheters are really doing a better job as compared to the ablation, the solid-tip electrode ablation that we may otherwise use. Ajmalin is optional. Be careful not to use it in severe Brugada syndromes and get in trouble. Generally, the target is localized in the RV free wall, so RVOT, RV free wall, and some rare extensions in the inferior wall. The procedure endpoint is the elimination of those potentials. Unfortunately, we cannot rely on having the Brugada pattern on the 12V DCG disappearing because this may take time. The goal is, of course, the absence of recurrence of VF, and the predictor for success for that goal is non-inducibility after ablation. Well, we put a question mark here. It's very unclear the role of inducibility here. But definitely the absence of type 1 pattern has been shown to be associated with better outcome. And the decrease of the spike in V1, V3. If you look at the literature, non-inducibility has been reported in 80 to 100% of cases. The disappearance of type 1, more 90 to 100% of cases, possibly with some delay, unfortunately. So this is something that is pretty consistently observed. And the absence of VF recurrence, which is at the end of the day what matters, is pretty good. You see around 90% again. This is a large study that has been reported by Nadimani and our group. Almost 160 Brugada patients with ventricular fibrillation. A significant number of them from Thailand. Epicardial excess in all, you see a pretty usual 25-minute RF delivery, 20% recurrences, and still some complications that are due to the epicardial approach. And I think we have to keep that in mind. Excuse me. This is never 100% safe. In this paper, in this cohort, 29% of inferior wall involvement, which is more than what we have in Bordeaux. Maybe it's more frequent in Thailand. But a very good outcome as demonstrated here. You have the events before ablation and after ablation. It's quite remarkable. What is interesting here is that if you abolish the pattern on the ECG, it's really a much better outcome as compared to when it persists. So it's good to have, unfortunately not an acute endpoint that you could rely on. And Carlo Paponi, just recently reported at ERA this year a interesting randomized study where patients would be randomized to either ICD alone or ICD plus ablation, 2-to-1 in favor of ablation. Enrollment is slower than expected, I suspect, but it's an interesting study and already a very significant difference in terms of events, so VT-VF in the ablation group versus the ICD group, where these events are happening but are, dealt with the ICD. If you look at the most recent guidelines, 2022 ESC guidelines, catheter ablation of either the trigger or the substrate for ventricular fibrillation should be considered for Brugada syndromes if they have shocks refractory to drug therapy, and we would certainly comply with that recommendation in Bordeaux. It's not a good idea in asymptomatic patients. I think it makes complete sense, particularly given the fact that it's not devoted for some risk acutely. Ablation in Brugada syndrome moved from targeting trigger to epicardial substrate. It's something that we've been witnessing for pretty much all type of VT ablation, I suspect. Ablation is pretty safe and effective in those patients with recurrent shocks resistant to drugs in experienced centers, and argmelin could be used, but with caution to avoid storms in those type 1 Brugada patients. Thank you very much for your attention.
Dr. Zhang's presentation.
Pierre, just for the audience, you're not recommending ablating from the endo without trying the epi first, right?
No, I don't think so. I mean, typically, the extent of the substrate that is really predominantly localized epicardially makes this not recommendable.
Because you have to ablate a lot of normal endocardium to do it.
Absolutely.
Yeah. And the idea of if you have to ablate a thin layer of epi, it didn't happen, obviously, but wasn't there a risk of reaching the coronaries if you're reaching that epicardial layer?
From Endo.
But it didn't happen.
No, it didn't, but I think it could.
Yeah.
It's probably less likely to happen because the coronary arteries are protected by the flow.
Yeah.
So it's probably not so easy to get if you ablate from a distance, which might be 4 or 5 millimeters, but it's possible, I suspect. And we may see a case one day, I don't know. I'm not aware of any case like that.
There aren't many people left in the audience. I just don't want them to think that it's a necessarily, it was the treatment when you had a big coronary vessel.
It is absolutely right.
I must say I saw about maybe 15 cases already by Carlo, and we did also a couple cases, but Brugada is not very frequent in Czech Republic. And I've never seen coronary artery which is in that area of outflow, which is usually ablated, because usually ablate quite high, and this is area typically without any coronaries. This is one remark. The other is that when you give ajmalin, it increases the area of these fragmented potentials, but they are usually some low amplitude and also not very high frequency. So it seems to be really in many patients probably more repolarization problem. And we saw also in a couple of cases where we did, these potentials were completely different from late potentials typically seen in other substrates. And also voltage is usually normal in that area. So I think it's a heterogeneous group. Probably patients in Asia are different from patients in somewhere else, and maybe it's some common. Maybe the phenotype is similar, but different causes or different genotypes. Nobody knows, but it's interesting. It works. That's for sure.
But at least on some, right? So in some patients, the pathology has been documented, and in some patients, the signal average ECG can be abnormal, but we don't have MR abnormal. And I know that I think there's been a report on unipolar electrograms perhaps being borderline in that area, reflecting some truly alteration in tissue characteristics on the epi. So I like you, are confused because I agree that they look like wavy signals rather than sharp late signals.
It's absolutely strange signal.
It's probably a very patchy type of condition where it's abnormal as compared to something more dramatic for the other type of substrates we are dealing with.
You mentioned the problem with ajmalin in some patients. How about propofol? Propofol is one of the medications we should also is a relative contraindication for these patients. Do you use propofol in these patients or you don't? For sedation?
We may. It's not that often, but I don't think we had significant issues with propofol. We don't on a routine basis anyway. We try to stay away.
No more questions? So if there are no more questions, the next speaker is Dr. Peichl. Dr. Peichl will talk about papillary muscle, VT, and PVCs.
So, thank you, Joseph. And congrats again. That's great.
I'm very happy to see some that are brave enough to stay for a Saturday afternoon to learn more about EP. So my agenda is to talk about papillary muscle VT. Obviously, this is an entity that was recognized for many years, has a typical ECG morphology, and there's some characteristics that this represents or manifests more likely as a PVC rather than sustained VT. But from our point of view, it's probably the most important one. The ablation is sometimes challenging. In terms of the recognition on ECG, there are other kind of sites that should be differentiated upfront from the ECG. Probably arrhythmias originating from the conduction system is the most closest resembling this arrhythmia if the transition zone is V3 to V5. Generally, those that originate from the conduction system has this kind of pattern of okay, so how to change it to marker, laser. Okay. So the more resemble the smaller R, first one, and the bigger one, the more that one R from the papillary muscles are more resembling this kind of morphology with the first R wave, which is a bigger one than the other one. I believe it's very important to also mention that the anatomy can be very individual. This is just an example from echo, and we'll try to show a lot of echo examples. So this is quite large anterolateral papillary muscle, and this is different patient, and you can see that there's a virtually none or a non-existing papillary muscle, or at least in terms of the endocardial contour. So if you deal with this one, you need something to really visualize, because you end up somewhere in the middle of the cavity. Also, in the terms of the configuration, the papillary can be very kind of variable. So this is a compact posteromedial papillary muscle, posteromedial one, and this is kind of extended one with a long kind of body, and a very tiny one. So this is also something that should be kind of considered. And there's yesterday published a paper from Frank Bogun's group showing that if the multimodality imaging, you can also, actually this is not the presentation that I intended, I had a different one, so if I can just switch to the other one, which is not in here. I uploaded on a different one. Okay, I just don't know. So there might be connections between the papillary muscles. There may be connections to the papillary muscle wall. There could be different kind of connections that make the ECG diagnosis, also the ablation, quite difficult. What echo can help you, that sometimes the imaging quality might be suboptimal. People say, well, it's not that very nicely visible. This is sometimes the reality, but we have other options how to really somehow see the papillary muscles better. This is just how, if you put the echo through the left atrium to the transmitral to the LV, so the posteromedial papillary muscle can become very nicely visible. So then you can really appreciate all the details of the structure and maybe do the ablation very selectively. So this is an example, illustrative case how the ablation can be done, a monobigeminy of this transition V3 to V5 with positivity in 2,3 AVF. And this is kind of showing somewhere probably anterolateral papillary muscle. And when we start to map, we usually just try to visit all the different parts of the papillary. So this would be this septal head. There is some whitening already, some fibrosis probably, which may and may not be relevant to the origin of the arrhythmia. And the prematurity is not bad, but not that striking. So then you move into between these two heads, and you have a bit better prematurity. And if you visit this lateral head or maybe accessory papillary, you may see an even better and or earlier signal with a tiny fractionate or fragmented potential in the beginning. And you may verify the origin by pace mapping, but to stabilize the catheter there for a longer time, it's maybe not that easy. So the pacing sometimes looks like this, and that might be a sign of catheter instability. But if you start to ablate, you usually see also the acceleration of the ectopy. This is a very common scenario. It's not very specific, it's actually non-specific, but this usually happens, but this would be optimal result that after a short application, you have abolished the ectopy. We analyzed our data already some time ago from 4 centers here in Central Eastern Europe, and these procedures were guided by ICE, which led to the acute suppression in the 86% and 74% was the complete elimination, which was also reflected on the Holter monitoring. We also looked at what is the most common site in terms of the long axis of the papillary muscle going from the tip maybe to the base of the papillary, and at least in our kind of cohort, those ectopies kind of were most commonly at the tip of the papillary. Obviously, some of those cases were reduced, so maybe the tip is the difficult part, which was not addressed properly in the previous procedure. There is other arrhythmias, not only from the left side, but also from the right side. This is complex anatomy of the papillary, anterior papillary muscle and the moderator band, as it was shown yesterday in this case reports very nicely. And the most common on the right side source for papillary ectopies are from the septal papillaries. They are very tiny, so you don't probably need echo to really display them, but the anterior and posterior ones you probably need. This is an illustrative case how complex can get if you attacking these ectopies. This is the morphology of a patient with multiple episodes of VF and ectopy triggering these polymorphic VTs. And if you really look at this morphology, I believe you saw this. This is actually something that is compatible with moderator band connection to the anterior papillary muscle origin, and this was exactly the same. So endocardial ablation, this would be the moderator band, and this was the catheter at the junction of the close to the anterior papillary muscle or base of the papillary. It was during sinus beat. There is usually this kind of fragmented high frequency potential of the conduction system, terminal portion. And it becomes very early during the triggering ectopy and ablation there. So obviously this is just to show how complex can be, and these arrhythmias can relate because this one originates at the junction of these two structures. There are already available kind of systematic meta-analysis of ablation of these arrhythmias. The mean acute success rate is close to 90%. The long term is less satisfactory. There are some factors associated with the better outcome, and this is the use of intracardiac echo, use of irricardiate or contact force sensing catheters. On the other hand, if you have a patient with already pre-existing cardiomyopathy or a multiple valve prolapse, that's the marker of probably having a poorer outcome. So there are different reasons why the success is not 100%. One is obviously the stability of the catheter on this very highly movable structure going up and down. This is not a good contact for the RF and lengthy ablation. This is somehow better if you can embed it or somehow kind of get in kind of a good and position on the papillary, that you have a synchronous kind of movement between the papillary and the catheter, then you can deliver at least some lesion. And the situation is even more complex because when you start to ablate, usually you accelerate the ectopy. This is, as I said, non-specific, but this is slowed down ice image, and maybe it will be appreciated. There is, during this acceleration of the ectopy, the ventricle will contract, and there's no time for diastole, so the whole RV, in this case, will be like a contracting, and the catheter moves more to the base. And there is a diastole, which will start now. This is the diastole, and the catheter moves more to the tip of the papillary, just to demonstrate how the movement is difficult to control. Even if you have a perfect site, you start to ablate, it will dislodge the catheter if you're using RF energy. That's why people use cryo. There are series in the literature of cryo ablation for failed RF procedures. This is a series of 16 patients. The problem here is that some of these cryo catheters are quite bulky, and you have to use the larger ones. This is a example from our experience. This is an unstable catheter here. If the cryo, whatever movement is there, the cryo will stick to the one side. If the side is correct, you probably do the lesion right. But in this series, there was also one major complication using these bulky cryo catheters. There are more data in the literature about the contact force and use of ice, that it may improve to really high kind of success rate for these arrhythmias. There are also other reasons to consider or parameters or factors. For example, this is just to show from the McAlpine Cardiac Anatomy Atlas how the axis of the papillary is if you put your catheter retrograde. And in this case, you can see that the catheter is in the long axis of the papillary, so it gives you quite a good way how to really visit different parts of it. And that for the posteromedial, that's our first line approach. If you go transeptally for the posteromedial, you see that you're off the axis, so sometimes it's not that easy to get in a good contact. So obviously this may be changed in individual patient, but just to show you that sometimes to change the access route may help you to really kind of get a better contact or better result. The problem is even more complex because these arrhythmias are often associated with mitral valve prolapse because they may signify some mitral disease and elongation of these papillaries. We have a recently published document, expert consensus on this. And there are also data for ablation in the mitral valve prolapse. And generally, it's more difficult, I would say, because it's usually bileaflet disease, and there are more of fibrosis in these papillaries, or just more difficult to get, but they're serious in the literature showing that the complete elimination can be still reached in kind of considerable number of patients with a clinically reasonable decrease of a PVC burden. There are also data about ablation of the sustained ventricular arrhythmia in this population, and they have different origins, some of them being very, very basal, something which goes to the direction of mitral annular disjunction as a source of fibrosis, but it seems that recurrences seems to be higher than expected. And sometimes you may be surprised because we should sometimes think in the broader perspective. This is a lady that had 3 previous failed procedures for ablation from papillary muscles. So in such case, you should think not only for PVC, but in a broader perspective, and this time turned out to be potassium channel mutation, something as a genetic disease, probably not treatable by focal therapy inside the ventricle. This is just to summarize our experience, small numbers so far in the patients with mitral valve prolapse. I was surprised that really there might be some overlap with this very otherwise refractory PVCs from LV that we cannot get with some genetical diseases. Titin was found 3 times, potassium channel was also found, but still in terms of the clinically reasonable decrease of burden, but something also just to show you that you should think in the broader perspective that there might be some other diseases, not only the focus on the papillary muscle. So let me conclude this talk. Just some practical aspects of the ablation, that selection of the appropriate patient is necessary, especially if you have somebody with a great pleomorphic ectopy, some different sources. You may think of some other diseases rather than the focal therapy for these. ICE is definitely necessary for these intracavitary structures because it can show you the anatomy. If you unsuccessful in our view, sometimes we just change the axis, which might give you, especially for posteromedial papillary muscle, but there are other ways, for example, the cryo. And this is the current our approach. Thank you for attention.
Questions from the audience? Is there any pre-procedural imaging that you think is helpful or maybe beneficial for these patients?
We really rely on ICE, so currently we don't do pre-procedural imaging. It may make a sense in those failed cases that you couldn't really do it, to just look for some other reasons why these patients do have such amount of ectopy originating from that region. including maybe some considering the genetic testing, at least what I've seen so far. Maybe that's too bold to say. But generally, obviously, you want to know that there is a mitral valve prolapse, because those patients are more difficult to, at least in my experience, to really, because they have bileaflet involvement. I'm aware about your recent paper about multimodality imaging, showing these connections between papillary muscles, connection to the annulus, connections to the wall. This may all play a role if they're present. They may make the ablation more difficult because they may somehow obscure the true location, because they rapidly make this kind of propagation from the one single foci more to the different directions and more difficult to map.
Yeah, I agree. What you said is key in doing the ablation procedure. Now, when you have prolapse patient, it's definitely helpful to, also for risk stratification, to have more imaging like a CMR before the procedure. And it's not uncommon that if there are lesions on the CMR, that they can correspond to the location where these arrhythmias can come from too. But I was surprised by the difference between the intracardiac echo and the much higher resolution CT images, how much those papillary muscles are connected to their environment, that we cannot easily appreciate with the eyes unless you put it to some other locations where you have a better view of it. But often we miss these connections, and arrhythmias can come from these areas. Often they have a little bit of a different morphology, because sometimes these connections go more towards the base, and then you see a different pattern of the PVC. Are there any other questions? Yeah, Dr. Maschlinski.
Peter, to comment on two things. One, pacing and the role of pace mapping to help, not necessarily completely guide, but to sort of adjust where you are on your pap muscle, whether you're anterior, medial, or lateral, and whether you use it at all. Because some people say, don't use pace mapping, and I find it gets you oriented.
That there are a lot of limitations there with this. So obviously you want to, if you have not frequent ectopy, this is the way you have to take, because then you at least know to locate or target your area of interest more to the septolateral, anterior, posterior, whatever is the part of the papillary. So yes, that might be, but for this fine kind of refinement, just locating the site, definitely activation mapping would be preferable, especially for these different routes that these ectopies can take. So if you record the earliest activity out of them all, it's probably very close to the source. If your pace map is right, you may not even get the pace map right, because you have a preferential conduction over one of the other routes that are present in the natural situation.
And can you comment on energy delivery and whether you'd ever consider, well, two things. One, the risk of higher energy delivery in normal myocardium off the papillary muscle, and would you ever try to isolate the papillary muscle?
Because of these connections, I believe the other ones, unless it's very tiny and thin kind of band of muscle, it's really not realistic because of what you say, and it's the most common scenario. So isolating the whole papillary, there are data in the literature from Chinese group to demonstrate that, but I believe that's quite tough, and then we sacrifice a lot. On the other question about the power delivery, if you're very touching the papillary, you have no gout contact, we go 40, 50 watts, because I believe that's safe. But once you get really deep into the myocardium, as you said, it's a usually non-diseased, non-scarred myocardium, and if you just deliver high power there, this is the papillary, you should go high. You may end up in the perforation, and to be honest, we had one case just like that. So we learned there that just this high power should mean that you are on the tip or close to the tip, not on the base.
And I think that the concept of isolating the papillary muscle is really ill-advised, because you have to get basically to the base. And that's the highest risk area, even if you slip off. But if you're purposely doing it in a healthy heart, it seems like at the very least you'll end up with incredible amounts of tissue destruction. And
if we know that most of these 2/3 are from more apical parts,
absolutely. So
it's
it doesn't make sense to
too
do
much
it.
damage.
But even the concept is not to be recommended.
The most important part, which I would also stress, is that if you have a real pleomorphism of these, every ectopy is a bit different. You should really step back and really think in a broader diagnostic perspective. What's this disease? Because you may prevent some unsuccessful, because you cannot really treat genetically based disease by focal ablation, because you just do one source and there will be many, many others. That's just the fact. And we had this scenario.
We had one also, and we chased it back and forth between the papillary muscles. I thought we maybe have had a minor effect, and then we gave up, and actually antiarrhythmic drugs worked very well.
That's the niche, I believe, indication for antiarrhythmic drugs.
That
This genetic
lady
disease.
showed she takes flecainide, and she's 0 ectopy, and she used to have a lot of ectopy and no effect of ablation.
In keeping with this issue of complexity, how frequently do you happen to have a concomitant pattern of seemingly outflow tract origin in polymorphic VTs from the papillary muscle? And do you believe this is related to interconnections, or do you believe this is kind of a syndromic type of pro-arrhythmic pattern?
Generally, in this series, I don't remember a single case that we would ablate, and we would probably, because the RVOT seems like an easy target to get, that we would go for RVOT ectopy. So it's not a common scenario, at least in our experience, to have both left-sided papillaries and RVOT. And usually we try to bring into the EP lab those that have a kind of monomorphic ectopies. If there are two sides, that's already worrisome. Obviously, if one of them is typical RVOT, that's something doable. But I've seen probably more a combination of RVOT and AVNRT rather than papillary muscle and RVOT, in my experience.
We've had two cases where
LVOT.
RVOT PVCs, late coupled, followed by the short coupled muscle moderator band, PVC triggering polymorphic VT. But it was always that you had the couplet.
The question is, what's the triggering PVC? It's the RVOT PVC, or it's the moderator band PVC. There may be coincidence because the RVOT is so frequent. So I don't just I believe it's the moderator band that triggers these arrhythmias, and that might be just a bystander, in my view, but obviously.
Yeah, in the one case when we ablated the outflow tract, it just stopped. Of course, we were frustrated, but we had an ECG morphology, and we're pacing right at the junction of the moderator band and pap muscle, and the patient has not had subsequent recurrences, so we don't know whether it was the outflow tract PVC ablation or the pace map guided moderator band pap muscle ablation.
Okay, if there are no more questions.
So then we have the last presentation, which is by my co-chair, Frank Bogun, and he will talk about sarcoidosis. So that's a really challenging situation, and we look forward to hear something more.
Thanks very much. Good afternoon and congratulations. You made it to the last talk. We use a stepwise approach when we have patients with VT-VF in cardiac sarcoidosis based on our experience that was published a few years ago. The first step is to use systemic steroids. The second step, if this does not work, is to add antiarrhythmics, single or in combination. And if this fails, to proceed with an ablation procedure. It's based on 21 patients who presented with VT or VF. in whom we tried immunosuppression and antiarrhythmics. This approach was successful in 12 patients. In 2 patients, immunosuppression alone worked. 4 patients, antiarrhythmics worked. And in 6 patients, the combination was effective. This was not effective in 9 patients. 5 patients underwent an effective ablation for the VT. In 4 patients, the ablation was not completely, but was partially successful. In 10 of the 18 patients in whom immunosuppression was used, this was beneficial, and this is of key importance in treatment of these patients. This is an example of a patient like this, 49-year-old woman, history of, at that point, dilated cardiomyopathy, ejection fraction of 25%, presenting with VT-VF storm. Bronchial biopsy showed non-caseating granulomas, and FDG PET showed increased FDG uptake. Steroids were started, prednisone 40 milligrams a day. These were examples of her arrhythmic events. This is the near-field recording from the ICD. You see polymorphic VT and a shock, polymorphic VT, stabilizing to monomorphic VT, fast VT, a shock. Here's ventricular fibrillation and a shock. In this patient, patient did not have any more ICD therapy after intervention of after initiation of immunosuppression. The ejection fraction normalized. Steroids were weaned off. The patient was off antiarrhythmics prior to the use of immunosuppression. She failed amiodarone, by the way. I did not mention that. And patient is currently on methotrexate, is doing fine. This was about 6 years ago. Now, patient 2 is a different patient, 47-year-old patient presenting with complete AV block in 2016. Initially underwent pacemaker implantation, that was changed to BIV ICD, upgraded to BIV ICD. Patient on his CMR had late gadolinium enhancement in the basal anteroseptum. A PET study was performed that showed increased FDG uptake in the anterior and inferior septum with associated perfusion defects. Ejection fraction was 40%. There was basal thinning. Cardiac sarcoidosis was suspected but not proven by bronchial or cardiac biopsy. Patient met the criteria for cardiac sarcoidosis based on the 2017 revised Japanese criteria. Patient was admitted with VT storm and had VT below the ICD cutoff rate. So the patient has ongoing inflammation and is admitted with VT storm. And at that point, we decided to proceed with an ablation procedure. At that point, the diagnosis of sarcoidosis was not completely sure. This is the patient's presenting ventricular tachycardia, 12 lead of it, below the ICD cutoff rate. These are the 2 ventricular tachycardias that we could induce in the EP lab. VT1 is the clinical VT, VT2 is another VT. Those were both reentrant VTs that we could induce and terminate with overdrive pacing. This is the patient's MRI. You can see that there is transmural scar in the basal short axis view that extends here to the subendocardial and then the subepicardial left ventricular free wall, and also to the right ventricular free wall. Here's the short axis view, septal involvement. This corresponds to low voltage in the bipolar voltage met in the RVOT, and not just the RVOT, but also the LVOT, as you can see this, since this continues over there. We started the mapping procedures in the lower outflow tract. This is the septum, and had preserved voltage there, but isolated potentials here. And this was literally one of the first locations where we had a catheter, and we was interested to see what is the pacing response here. And we can actually, at this location, replicate very closely the ventricular tachycardia VT number 1. So we wanted to see, is this a critical location or not? So we tried to induce the VT, but we induced VT number 2 and performed here entrainment mapping. And actually have a very long stimulus QRS interval, and the post-pacing interval falls somewhere here into this area. When we paced some more, can see this one, this stimulus is not capturing. This is a capturing stimulus with a long stimulus QRS interval, but this stimulus does not capture subthreshold and terminates the ventricular tachycardia, and the next capturing beat matches up with ventricular tachycardia number 1, all that on the same side in the right ventricular septum. So we decided to turn on radio frequency energy and this terminated the VT, and the VT, neither VT1 or 2 were inducible after this ablation lesion. But we kept mapping. We were interested in see what other things we find, and mapped the sinus of Valsalva, since this area was also involved. And again, this is the VT morphology, and we have matching pacemakers with a long stimulus QRS interval here. And when we paced some more at the same left sinus of Valsalva, we see some very unusual locations there. Again, the comparison now VT number 1, and this is similar to what Dr. Marszlinski described yesterday with the paired VTs. So we have some shared isthmus here in this region, in this particular patient. In follow-up, the PET study was negative for inflammation 3 months after the ablation procedure. The patient was, in the meantime, started on immunosuppression. The ejection fraction remained stable at 45 to 50%. There were no further VT episodes since October of 2017. The patient was maintained on low-dose prednisone, Cellcept, and no antiarrhythmics. There are many challenges that we face when we have patients with cardiac sarcoidosis. The substrate is multifocal, involving often the left and the right ventricle. It is often intramural. Actually, the lesions often start intramurally and reach the epi or endocardium by extension of the lesions. There may be various mechanisms that may be operational. There may be re-entry in the myocardium, re-entry in the fascicles, or there may be focal triggered activity. And the substrate, most importantly, also changes over time through cycles of inflammation and fibrosis. This is 4 patients with different patterns of LGE that affects here the septum, low septum transmural scarring here, the entire septum, intramural, and then transmural reaching out to the epicardium and the right ventricular free wall. Here, extensive RV free wall involvement, multifocal, intramural, subendocardial, and epicardial LV involvement, and here chest involvement of the left ventricular epicardial free wall. Here, there's also papillary muscle involvement in this patient here. We published our data from a multi-center registry recently. These data were reported from multiple centers in the US and Europe, including patients with definite or probable cardiac sarcoidosis, ablation of monomorphic or PVC triggered VF patients were included. We looked at the acute and long-term outcome. The study population was young. These are young patients. They have mainly preserved ejection fractions, and the majority were either antiarrhythmic medications or immunosuppression prior to the procedure that was failed these medical management. These were long procedures involving multiple cardiac chambers. Success rate was a little bit more than 50%. Partial success 26%, failure in 6%, and no testing in 26%. This resulted in a significant reduction of the ICD discharges. Long-term outcome, median follow-up for 2.5 years, 46% of the patients, very high recurrence rate. If multiple procedures were done, 63% of the patients had no recurrence. The patients who had the severest presentations of VT storm or incessant VTs, looking at those patients, 57% had no recurrent VT post-ablation, and 25% had occasional recurrence, resulting in 82% elimination of VT storm in these patients. Post-ablation non-inducibility was not associated with long-term outcome, but ejection fraction pre-ablation, lower ejection fraction, or inflammation at the time of ablation was associated with an adverse outcome. Now, what about active inflammation in these patients? The majority of these patients, when we took them to the lab, the last PET study was still positive. Non-inducibility, it didn't make a difference whether they were positive or negative. VT recurrence, however, the VT recurrence was much higher in patients who had positive PET studies. Now, looking at the patients with positive PET studies and VT storm and incessant VT, so the worst of the worst, those people failed antiarrhythmics and steroids, the majority of them, and you're standing with the back to the wall in these patients. So it's interesting to see that the VT recurred in 48 patients, so not much more than in other patients who were negative. And the ICD shocks, importantly, were significantly reduced at 30 days in this patient population. Now, this is a patient that has this kind of a scenario that I'm going to show you data from. 35-year-old woman with recurrent polymorphic VT and VF, had FDG uptake in the inferior septum, a lot of SUVs here, 11.2 compared to the blood pool. So very intense inflammatory process. RV free wall uptake also, and perfusion defects at the sites of increased FDG uptake. Both of these parameters are associated with adverse outcomes in these patients. With immunosuppression, the VF and the polymorphic VTs, they were suppressed. However, the patient had recurrent slow VT and IVR refractory to immunosuppression and amiodarone with frequent PVCs that she was very symptomatic with. So we attempted an ablation in this patient in the RV and the LV. This is the idioventricular rhythm that the patient had, and the rate was variable. The morphology was relatively similar. Rate varied from a heart rate of 70 to 130 to 140 beats per minute. This arrhythmia was not inducible. It was not pace terminable either when we had her in the lab. This is the FDG PET that we have, a short axis view of the FDG PET showing that this is septal inflammation, uptake, inferoseptal, and this is the RV free wall LGE uptake, not LGE, FDG glucose uptake. This is the corresponding PET study showing decreased perfusion in the same segment. This is the this is the 3D reconstructed MRI and CT combination showing the LGE in this patient on the septum. There's some sparing here. And this is the superimposed inflammation here. This corresponded in the electroanatomic voltage map. This is the left ventricle, this is the septum, to this area of low voltage, and this is the right ventricular voltage map. The arrhythmia came from this area, and we carpet bombed this area with extensive ablation from both aspects of the septum. This was the MRI before the ablation procedure, transmural LGE. This was a month after the ablation procedure. You see a lot of this dark core, which is probably from microvascular obstruction, which persisted more than 100 or 110 days after the ablation procedure. VT recurred after amiodarone was discontinued. Another VT ablation was planned, and when the patient was admitted, they did a right heart catheterization. It was considered that the patient had worsening right heart failure, and a cardiac transplantation was performed and performed instead. In conclusion, inflammation associated with arrhythmias often coexist of rapid VT, polymorphic VT, and VF. In the setting of an inflammation in polymorphic VT and VF, immunosuppression and antiarrhythmics are beneficial. Ablation most beneficial in the non-inflammatory phase. Ablation reduces the antiarrhythmic drug requirement in ICD shocks. Ablation is effective in the setting of VT storm, even in the presence of inflammation, unfortunately not in all patients. Impaired pre-procedure ejection fraction, FDG uptake in PET were associated with adverse outcomes post-ablation. This completes my presentation. Thank you for your attention.
Thank you very much. Questions, comments? Petr.
Thank you very much for a nice presentation. My question is we yesterday heard from Joseph about the radiotherapy for refractory arrhythmias, but maybe could be the sarcoidosis the one disease that could be suitable for this, because these inflammatory cells are more responsible to radiation than the other ones. So it could be their efforts in the world trying to use this therapy. There are some data from the brain sarcoidosis that this might work. Have you any idea? Is it a good idea to do?
Yeah, there are not many. We had at the Heart Rhythm meeting, we had a session where we talked about this. I think that there are a total of 5 cases that have been done. I had to leave early because I had to catch my flight. Fred was giving the presentation, so he asked beforehand, because we have this sarcoidosis registry, and so we kind of connected all until we found 5 patients that he presented. I showed you the substrate. The substrate is extremely variable in these patients, and I'm sure there are some patients who are suitable for this, but a lot of these patients have extensive scarring. Unless you can really pinpoint down where the arrhythmia is localized, you don't want to radiate too much in these patients. You have to have a good understanding where is it coming from and what to radiate. And if there is such an extensive substrate like in these patients that I'm showing you, I don't think radiation, unless you know exactly where you want to go. We have done this in a few patients, and it didn't pay out. The ejection fraction in some of these patients is already low, and if you radiate too much, it's gonna keep going down. So we didn't have good experience.
I'm aware of one case which will be published, and they combined total heart irradiation with 2 gray in different sessions, and then localized for VT ablation. And they claimed that it's really stopped the inflammation. The patient had quite long follow-up, few years without any recurrences of inflammation and without recurrences of VT. But that's the only case I'm aware, which was interesting.
So radiation cured the inflammation too?
Yeah, they did the whole heart radiation therapy with 2 gray, like small dose with the different fractions, and then localized for VT ablation.
Yeah, when we have been doing the radiation, we use 25 grays to target a specific area.
Of course, but that's for a specific area. But there was combination of total irradiation and localized.
Yeah, but on the other hand, if you really want to have an effect of a local substrate, you may not reach that with 2 grays. I mean, if it has effect.
That's what I'm saying. 2 grays was for the whole heart inflammation, because the patient was on immunosuppressive prednisone, still having a lot of inflammation and still having VT. So they first used the total heart radiation to keep down the inflammatory process, and then localized for VT. But there was one case I'm aware of, and it should be published. Okay, if there are no more questions, thank you very much. And Paolo will tell you a few words at the end of this symposium, probably where will be the next one. And I will tell you a few words just to close the meeting.
Well, first of all, thank you, Joseph, because really I think that organization, location, and logistics were outstanding. So we really enjoyed these 2 days. I can tell this for everybody. Program was really remarkable. I really have enjoyed every single session, and I think that really, I hope that beside the people that were here in person, many others may have joined and maybe in the future benefit from listening to this. For sure, TogetherVT is a great initiative. I think that we should really try to keep it on, and maybe next year, not maybe, Katja Zeppenfeld has agreed to organize and host the next TogetherVT in Leiden. That is in a date should still be decided. We don't know whether this is going to be about 13, 14, 15, or 2021 June, but of course we try to reach all of you and maybe others more, I think, by advertisement. And I think that, having said that, I wish you a very nice weekend, a nice trip home. Thanks for coming, and to the next time.
And also, I would like to thank all of you for coming. I hope that you enjoyed also the meeting. I would like particularly thank to all this scientific committee. We are, as you heard, we are 6 people, and they really helped to put this program together. I would like to thank to the CCL company and all organizers for logistics, and also to all our sponsors who made this meeting possible. And I wish you a safe trip home, and hopefully see you next year in this meeting or somewhere in between in different meetings. And enjoy the rest of the weekend. Yeah.